Hello, all of you from different parts of the world. Once again, I am Marcelo Bonecker, the president of International Association Pediatric Dentistry. It's a great pleasure having you here with us. I would say good afternoon to you because it's 1:30 in my country, Brazil, São Paulo. And I would say good morning to Professor Jorge Casian because it's 11:30 in the morning for him in Mexico City, Mexico. So, oh, you are in Veracruz, right?
In Veracruz, yeah.
Okay,
yeah,
sorry about that. In Veracruz, in Mexico. So, welcome all of you. Right now, we're going to have a lecture from Professor Jorge Casian. It's going to be our last lecture from the IAPD Virtual 20. This is going to be a very good lecture. Professor Jorge Casian is a former president of Mexican Academy of Pediatric Dentistry. He has a private practice as pediatric dentist and orthodontics in Veracruz, Mexico. And he is graduated from Dental School of the University Continental in Mexico City. His degree in pediatric dentistry is from the University of Intercontinental in 1988. And he has a degree in orthodontics from IADAP in 1999. He's professor of the Mexican Dental Association since 1991, and he's author and co-author of multiple publications and international speaker for many, many conferences all over the world. I'd like to remind you that this lecture is sponsored by New Smile, and I personally would like to thank Diane Johnson, who is the founder and chief executive officer. Thank you, Diane Johnson, for sponsoring the lecture and sponsoring this IAPD virtual event as well. So now, Professor Jorge Casian, the public's yours, so you can start giving your lecture. Thank you so much.
Thank you, Marcelo, for this introduction. Good morning from Mexico. In Mexico, it is about 11:30, so I just had my second cup of coffee. For me, is morning, so good morning from Mexico. I'm going to talk about zirconia crowns, how and when in Mexico, in Latin America, and I am sure that in many other countries, frequently we treat small children with early childhood caries that in some cases takes them to the loss of several teeth, especially the upper anterior teeth. Some of them with a typical pattern with the lower anterior teeth free of caries, but some other with an atypical pattern where all teeth have to be extracted. As we know, caries in primary dentition can lead to malocclusions and problems for the permanent teeth. We are in times of minimal invasive dentistry. I believe in it, and I try to do it when it is possible. I enjoy doing small restorations on small teeth with beautiful results with no anesthesia. But today, I'm going to talk about the challenge of restoring severely destroyed teeth with durable and aesthetic restorations. And I'm going to start this presentation sharing with you this clinical case. This is a 3-year-old kid. He was treated under general anesthesia by other dentists who did these terrible and anesthetic restorations. This was a non-cooperative boy, but after some minutes talking and explaining to him the procedure that we would do, we agreed to do just one restoration during that visit. And I decided to start working on the upper right lateral incisor because the cervical border of that steel crown was hurting his upper lip. So after some local anesthesia administration, I cut the crown to remove it I did a preparation to place a crown, and after testing a trying crown, the crown was cemented. This procedure was done in about 10 minutes, no more than 10 minutes. A week later, they came back. He was happy with his new restoration. He was so excited, and he was very cooperative with us. So, some local anesthesia was administered, and with a bore, I cut the crown of the central incisor from vocal to lingual in order to open it and to remove it. Look at this picture. Look at the gums. All that gingival damage was not done by me. It was done by the crown that he had. This is the preparation that I did. I did a preparation convergent to incisal. The incisal angles are rounded, and the finish line was placed subgingivally. Finally, both central incisors were restored with zirconia crowns, and the left lateral incisor was restored with some composite. Look at the X-ray. No pulporotomy or pulpectomy was done. Please look at the red line. Look at the position of that crown. After a week, the gingival tissue follows the new crown. So, the crown of the right lateral incisor was placed during the first visit, and the central incisors and the left lateral incisor were restored on the second visit. This is 3 years post-op. Look at the X-ray. Look at the crowns. Look at the gums. The crowns look as new. The crown looks beautiful. Frequently, we treat small children with severely destroyed anterior teeth, whose parents ask or demand highly aesthetic restorations. Stainless steel crowns have been used for more than 70 years, and we are still using them with clinical success. This is important, with clinical success. We love steel crowns, but it is a fact that most of our patients' parents don't like them, especially for the upper anterior teeth. In pediatric dentistry, this, among others, is one of the most important evolutions that we have. The transition from the stainless steel crowns to the pediatric zirconia crowns. And look what beautiful restorations we have now. And of course, they are a good restorative option for clinical cases with correct indication for placing crowns. A highly polished restoration is more aesthetic. A highly polished restoration causes less wear to the opposite teeth. A highly polished restoration leads to less biofilm accumulation, less biofilm buildup, so it's easier to clean. Look at this picture. The upper central incisors are zirconia crowns. The upper right lateral incisor is enamel. The upper left lateral incisor is a composite restoration. Biofilm accumulation on the lateral incisors, no biofilm, no plaque accumulation on the central incisors. Let's have a closer look. Look at the lateral incisors. Look at the crowns. The crowns look clean. Let's have a closer look. Look at the gums. The gingival tissue around the zirconia crowns looks healthy. That is because one of the most important advantages of the zirconia is to be biocompatible. And talking about that, I would like to share with you this clinical case. This is a 20-month-old little boy. He was treated under general anesthesia. And I placed two zirconia crowns on the central incisors and two pre-veneered steel crowns on the lateral incisors. This photo is after a week. Look at the gums. This other photo is after 3 months. And this photo is very important for me because it shows the difference in healing process comparing zirconia crowns on the central incisors versus steel crowns on the lateral incisors. The gingival tissue around the zirconia crowns looks healthy, but the gums around the stainless steel crowns after 3 months still shows some inflammation. 4 months later, this kid fell down and his right central and lateral incisors were avulsed. He came back to my clinic 3 years later, and he did it because he had caries on that upper first primary molar. And I took some photos, and the first thing that came to my mind when I saw this photo was biocompatible and no biocompatible. Look at the gingival tissue around the steel crown. This last photo is 5 years post-op. This clinical case is published in the first book about pediatric zirconia crowns in the world. This book was written by Dr. Song-Ki Kim from South Korea. And Dr. Kim is who developed zirconia crowns. Let's compare these two kinds of restoration, stainless steel crowns versus zirconia crowns. Stainless steel crowns are non-biocompatible and non-aesthetic. Zirconia crowns are biocompatible and aesthetic. Stainless steel crowns, good clinical performance, proven for more than 70 years. Zirconia crowns, good clinical performance, proven for more than 8 years. No special cement is required to place a steel crown, while resin-modified glass ionomer cements or resin cements are strongly recommended for cementing zirconia crowns. Less tooth reduction is needed to place a steel crown. Of course, we know that. That is why, currently, we are teaching a way to do the preparation using some depth cuts as a guide to know the amount of reduction needed to place the crowns. Those depth cuts are done with specific bores with specific measures. I will try to summarize the preparation with this picture. Please just imagine this is a severely destroyed central incisor. So the first step is the incisal reduction. We need to do about 1.5 to 2 millimeters of incisal reduction. Then we will do mesial, distal, vocal, and lingual reductions all around that tooth. The preparation should be convergent to incisal. So we will do more reduction here and less reduction here. The incisal angles should be rounded and the finish line must be extended subgingivally in order to have gingival health. Of course, a more aesthetic result, more retention area, and that is very important for us. And to avoid the cervical border of the crown to be exposed. The next step is the test of the trying crown, and the last step is the cementation of the crown with a resin-modified glass ionomer cement. After a week, look at the gingival tissue, looks healthy. And some years later, after the exfoliation of that tooth, this is the cervical adaptation that we could get if we do a correct preparation and, of course, a correct crown selection. Let me share with you some clinical cases. This is the first one. This is a 3-year-old boy, a very cooperative patient. He visited me because he had an abscess in the apical area of the upper right central incisor. I took an X-ray, and after some local anesthesia administration, I placed a rubber dam, and I did a pulpectomy on the right central incisor, and I did a pulpotomy on the left central incisor. The pulpectomy was done with some Vitapex, while the pulpotomy was done with Neopuri. And Neopuri is a premixed MTA by NewSmile. I did the preparations to place the crown. Look at the preparations. They are convergent to incisal with finish lines placed subgingivally. And after testing, trying crowns, the crowns were cemented. At this moment, I would like to talk about the position of the crowns. Look at the crowns. For a better aesthetical result, the position of the crowns should match with the root alignment. Look at the crown of the right central incisor. It is in a correct position. Look at the crown of the left central incisor. It shows some inclination to distal. I did a little mistake when placing the crown. Maybe I placed extra pressure when cementing that crown. The crowns look good, but let me show you what we can do to improve the aesthetic appearance. A couple of days later, after the cement was completely set, I took a finishing diamond board, and with a lot of water, I did some reduction of the incisal border of the crown of the left central incisor, and then I polished it. And this is what I got. It was Christmas. In fact, it was the day before Christmas. As I told you, this is a very cooperative boy. He was happy. This is 3 months post-op. In this photo, we can see the reduction done. 9 months post-op. So this is before and after 9 months. This is a very interesting case. This is a 3-year-old girl. As you can see in this photo, she has a composite restoration on the left central incisor, placed by other dentists some weeks before. Those anterior teeth were completely asymptomatic. This was a cooperative patient, but just for some minutes, maybe 5, maybe 7 minutes, and it was all. Her parents didn't want me to treat her under sedation or general anesthesia. So we decided to treat her under local anesthesia in 3, maybe 4, very short visits. Let me tell you how I did it. On the first visit and after local anesthesia administration, I placed a rubber dam and I did pulpotomies on the right central and lateral incisors. After controlling the pulpal bleeding, a wet cotton pellet moist with some sodium hypochlorite was placed inside the pulp chambers for about a minute, maybe more than a minute. After that, the pulp chambers were rinsed with some saline solution. MTA was mixed according to the manufacturer recommendations, and it was placed inside the pulp chamber. MTA was slightly condensed with a moist cotton pellet and then was covered with some resin-modified glass ionomer cement in order to protect it. During the second visit, I did the same on the left side. I did pulpotomies on the left central and lateral incisors. A couple of weeks later, they came back. And with a low-speed round bore, I removed some of the MTA that I had placed in order to have more retention area and more etching area. And after etching those teeth, avoiding etching MTA. MTA shouldn't be etched. Those teeth were built up with some composite. I did preparations to place the crowns, and the crowns were cemented, in this case, with a resin cement. So this is the pulp, MTA, in this case is neo-MTA, and the crown cemented with resin cement. How did I get retention? Number one, by removing some of the MTA that I had placed and building up those teeth. Number two, placing the crowns subgingivally. And number three, with a correct cervical adaptation of the crowns. So this is before and after. 30 months later, they came back because she had pain. She had an abscess in the lower first primary molar. That tooth was extracted. And I took some x-rays. Look at the x-rays. Look at the crowns. Look at the roots. As you can see, the second primary molars were restored. I placed a steel crown on that lower first primary molar. The primary canines were restored with some glass ionomer cement. And of course, I placed a couple of space maintainer appliances. 36 months post-op. From my point of view, pediatric zirconia crowns are the most aesthetic, resistant, and durable restorations available for this kind of treatment for severely destroyed teeth. 4 years post-op. Look at the X-ray. The upper central incisor is erupting. The upper right primary central incisor will exfoliate soon. Look at the crowns. They look as new. And the question is this minimally invasive dentistry? What do you think? Well, I think that restoring severely destroyed anterior teeth on a non-cooperative girl, a 3-year-old girl, preserving pulpal vitality with durable and aesthetic restorations with more than 4 years follow-up, it is minimally invasive dentistry. And of course, if some of those teeth would be necrotic, I would go for pulpectomies. Some photos of this clinical case are published in this article written by Dr. Caroline Primus, and Dr. Primus is who developed neo-MTA and neo-Puri. And now I'm going to talk about the clinical application of pediatric zirconia crowns on trauma cases. This is an 18-month-old girl. She fell down, and as you can see, her right central incisor is broken. Look at the X-ray. How can we restore this tooth? It is not possible to do a pulpectomy. Look at the apex, it's completely open. In fact, she had a crown root fracture with a pulpal exposure. Again, I did a pulpotomy, that is neo-Puri. Neo-Puri was covered with resin-modified glass ionomer cement. Look at the position of the broken tooth. It is rotated, and the mesiodistal available space to restore the broken tooth was reduced. And in a case like this, I don't want to place a zirconia crown in a rotated position. I don't want to restore that way. Let me show you what I did. This is the preparation that I did. This preparation is converging to incisal. The incisal angles are rounded, and the finish line was placed subgingivally. With this preparation, I tried to correct the rotation, but the mesiodistal available space to place the crown was still reduced. So I had to place a crown smaller than the left central incisor, but the rotation was corrected. And this is the result, before and after. Another clinical case, this is an 8-month-old baby. The central incisor is broken and the pulp is exposed by more than a week. That tooth was completely asymptomatic. Look at the X-ray, look at the apex, it's completely open. So the treatment options were so limited. Maybe an extraction could be okay for this kid. And I really wanted to save this tooth. So after some local anesthesia administration, I placed a rubber dam. As you can see, I am holding the rubber dam with my fingers. Her mother was holding his baby. She was singing to him while I was treating him. In about 5 minutes, I did a pulpotomy. After controlling the pulpal bleeding, MTA was placed inside the pulp chamber, and neo-MTA was covered, was protected with some resin-modified glass ionomer cement. A couple of weeks later, they came back. I did a preparation to place a zirconia crown, and after testing the trying crown, the zirconia crown was cemented. 4 weeks later, look at the crown, look at the gingival tissue, look at the X-ray. In this X-ray, we can clearly notice that a dentinal bridge is being formed, which means that the pulp is alive. And that is amazing after just 4 weeks. Look at the last X-ray at the right side of your screen. Look at the dentinal bridge formed. Look at the gums. Look at the crown. Advantages to keep the pulp alive. Number 1, we will get thicker radicular walls. Number 2, we will give more time to the bone for maturation. Number 3, we will get better crown root proportions. And number 4, we will allow the apex to close. This clinical case won the Anna Fuchs Award in Pediatric Dentistry in 2018. But what makes this case so interesting? Of course, the first reason is the way it was treated. But to understand what makes this case so interesting, I would like to share with you some photos. This is a 13-month-old boy with an identical clinical situation. This boy was treated by Dr. Camila Palma in Spain. This is another case, a 10-month-old boy, and he was treated by Dr. Flavia La Roca in Peru. 3 identical clinical cases. No history of dental trauma, no history of pain, no history of complications during birth, no history of hospitalization during this first 6 months. And here we can see the restorative treatment done on each clinical case. So we think that we are facing 3 identical clinical cases from 3 different countries. And we believe these clinical cases are a developmental defect called preeruptive intracoronal resorption. All of us know cases of this entity on permanent teeth and on posterior primary teeth. But to our knowledge, there are no cases of this entity on primary teeth published. So this could be the first reported cases of preeruptive intracoronal resorption on primary incisors. These clinical cases are published in the Journal of the American Academy of Pediatric Dentistry on April of 2020. When we talk about developmental defects of enamel, we can find any tooth affected. One side or 2 sides, asymmetrically or symmetrically. And of course, we can find enamel defects in primary teeth. Look at this primary canine associated to hypomineralized upper second primary molars. Same patient. Another kid with hypomineralized lower second primary molar. By the way, the second primary molar is the most frequently affected primary tooth. Look at this primary canine. Look at the buccal surface of this tooth and the broken enamel at the distal face of this primary canine, associated to a hypomineralized lower second primary molar. Let's talk about restorative procedures. As pediatric dentists, we treat children with enamel defects in primary dentition. For example, this case, hypomineralized and severely destroyed second primary molars, both sides, upper and lower. We can treat this kind of cases with stainless steel crowns, with or without pulpotomies. And of course, we can treat them using pediatric zirconia crowns. Both kinds of restoration with excellent clinical results. This is after a year. After a couple of years, the first permanent molars are erupting. Look at the occlusion. After 3 years, after more than 4 years, occluding pre-made zirconia crowns against steel crowns, with no problems, with no marks or signs of excessive wear on the opposite teeth after 4 years. But what about permanent dentition? What about enamel defects in posterior permanent teeth? This is a hypomineralized lower first permanent molar on a teenager, and that is the pulp. Is she laughing at us? I think she is. Problems that we face at restoring. Number 1, problems to have enough anesthesia to do the preparation. Hypomineralized enamel is not good isolating the pulp. So the pulp used to have some chronic inflammation. That is the reason why those teeth have sensitivity. Behavior problems. If there is pain, the patient will not cooperate with us. Adhesive issues. Restorations that need to be replaced frequently, again and again. Parents and patients complaining about the cost of the treatment, expensive treatment. And I will add another point, that is aesthetic requirements or demands of the patient or the parents of the patient. And I think this last point is very important. By the age of 9, children with MIH needed to visit a dentist 10 times more frequently than the control group. And each affected tooth needed to be restored at least 2 times. This was published in 2017, and they found that 47% of composite restorations needed to be replaced after 34 months. It's not too bad, it's about 3 years. Maybe it is okay for a hypomineralized molar. While 63% of glass ionomer cement restorations needed to be replaced after 18 months, which demonstrate an erratic clinical performance of glass ionomer cement restorations on a medium term. Both kinds of restoration needed to be replaced, which can take children to extensive and atypical restorations too early. Look at this crown, an atypical restoration on a teenager. Of course, any kind of restoration has a limited life. Even stainless steel crowns can fail. This is an 11-year-old girl with MIH. She visited a dentist because she had a severely destroyed lower primary molar. She was so cooperative. She was smiling. She was happy until she knew it was a permanent molar. And due to the age of 11, her parents thought it was a primary molar. So they were waiting for the exfoliation of that primary molar. That is the reason why they didn't visit a dentist. That first permanent molar was extracted. Restorative procedures for hypomineralized permanent molar. That is a hypomineralized lower first permanent molar on a teenager. Amalgam restorations are not an option to restore hypomineralized molars and shouldn't be used, so I will not talk about them. For many years, we have been treating enamel defects in posterior permanent teeth with composite restorations with good clinical results if the margins of the preparation were extended into hard enamel and if the restoration was placed on the rubber dam isolation. So the key is rubber dam isolation to control humidity and extending a bit the margins of the preparation into no porous enamel. Number 2, with glass ionomer cement restorations with good, but sometimes an erratic clinical performance on a medium term. With a combination of an orthodontic band filled with cement. This is an interesting option too and should be used as temporary restoration. Number 4, with stainless steel crowns for those cases that needed full coverage. And currently, we have a new option. And I will focus the last part of this presentation on it. All of us know the advantages of using pre-made restorations. No impression is needed, no lab work is needed, low cost. Even in partially erupted molars, we can place pre-made restorations because we don't need to take an impression. And the crowns can be placed in just one visit. When we talk about zirconia crowns for permanent molars, our main concern is always the amount of tooth reduction needed to place them. The question is, should we be worried about that in this case? Or maybe in this other case, should we be worried about the amount of tooth reduction needed to restore this hypomineralized molar? How thick are the crowns? The thickness at the center of the occlusal surface of a zirconia crown for a permanent molar is about 0.7 millimeters, less than 0.7 millimeters, while the thickness at the tip of the cusp is less than 1 millimeter. So the amount of occlusal reduction needed to place a zirconia crown on a permanent molar is about 1.5 millimeters. We don't need to do more than 1.5 millimeters of occlusal reduction to place the crowns. There is no reason to say that we do pulpal communications during the occlusal reduction to place a zirconia crown. The thickness at the cervical part of the crown is just 0.2 millimeters. That is the thinnest part of the crown. That is the cervical adaptation of the crowns. So, this is a 10-year-old girl with MIH. She visited me because she had a lot of sensitivity in that tooth. She said that she had a metallic restoration on that tooth. Maybe a stainless steel crown, maybe a band with some cement. I really don't know. So I took an X-ray, and after some local anesthesia administration, with a big low-speed round bore, I tried to remove some of the carious dentin carefully. Of course, trying to avoid the pulpal exposure. Even when no pulpal communication was done, the pulp was protected with some MTA. No preparation was needed to place the crown. No preparation was done. I just placed the finish line 1 millimeter subgingivally. And after testing a trying crown, after controlling the gingival bleeding with some viscostat clear, and viscostat clear is aluminum chloride. The crown was cemented with some resin-modified glass ionomer cement. In this kind of cases, it is very important to take an X-ray to be sure that we are not trapping the second permanent molar with the crown. This procedure was done in about 20 minutes, no more than 20 minutes. 2 weeks later, look at the crown, look at the gums, and the tooth sensitivity had disappeared. After 3 months, 5 months, after a year. And the crown looks clean. This is my newest clinical case with zirconia crowns on permanent molars. This is a teenager. She came to my clinic asking me an orthodontic treatment. As you can see, she has a couple of steel crowns placed some years ago by other dentists. She said that when the dentist placed these crowns, the crowns were high. So he took a board to adjust the occlusion. So that is why we can see some scratches on the occlusal surface, and we can see the cement through those holes. In this X-ray, we can see that the second permanent molar is trapped by the crown of the first permanent molar. In this X-ray, we can notice an empty space between the gutapercha and the steel crown. So, this is a vocal view. Both crowns were very short. So after local anesthesia administration, I cut the crown to remove it. The preparation was modified. And after testing a trying crown, a zirconia crown was cemented. A lingual view of the crown just placed, before and after, and during the same visit, the first bicuspid was extracted. Look at the gums just after placing the crown. Look at the X-ray. And now the second permanent molar is free for erupting. We can see some excess of cement on that X-ray. A week later, look at the gingival tissue around the crown. A beautiful restoration. Now it's time to start working on the left first permanent molar. I am removing the crown, and look what I found inside the pulp chamber. A couple of cotton pellets were left there. So after cleaning the internal part of the pulp chamber, the pulp chamber was filled up with some glass ionomer cement. The preparation was modified. I am testing a crown, checking the occlusion, and the white crown was cemented. The first bicuspid was extracted. This is before and after. A couple of weeks later, some orthodontic separators were placed and a couple of bands were adapted and were cemented on the crowns. And the orthodontic treatment was started. I haven't seen these patients since March, maybe April, due to COVID, so I have the follow-up. I will call my next clinical case enamel and zirconia mountains. This is a teenager, and that is a second permanent molar, a hypomineralized second permanent molar. This is her first bicuspid, and this is her upper second premolar. And she came to my clinic with a lot of sensitivity. She had pain with any cold, hot, or sweet food, even with the toothpaste when brushing her teeth. So after local anesthesia administration, I placed a rubber dam, and with a low-speed round bore, I tried to remove the soft dentin carefully, trying to avoid a pulpal exposure. But to be honest, that was impossible. And after at least a couple of big pulpal communications, I decided to do a pulpotomy. After controlling the pulpal bleeding, a wet cotton pellet moist with some sodium hypochlorite was placed inside the pulp chamber for about a minute. After that, the pulp chamber was rinsed with some saline solution. MTA was mixed and one was placed inside the pulp chamber. MTA was slightly condensed with a moist cotton pellet and then was covered with some resin-modified glass ionomer cement in order to protect it during the setting time, and of course, in order to start the preparation of that tooth to place the crown on the same visit. The rubber dam was removed and I took an X-ray. This is the preparation that I did. And again, I did no preparation. I just placed a finish line subgingivally. And after testing the trying crown, after checking the occlusion, the zirconia crown was filled up with some resin-modified glass ionomer cement with biocem, and biocem is a bioactive glass ionomer cement, and the crown was cemented. The excess of cement was removed, and I took this photo. This is a lingual view of the crown just placed. This is after a week, and the tooth sensitivity had disappeared. Look at the occlusion. And this is important. When we are placing a crown on a second molar, if we place the crown high, even just a bit high, the anterior bite could be opened. So it is very important to check the occlusion, if it is possible, before crown cementation, and of course after crown cementation. If after crown cementation you notice that the crown is slightly high, the manufacturer recommendation is to reduce carefully the opposite tooth until the occlusion is settled. But if the crown is too high, you must remove that restoration. A month later, look at the photos. A beautiful restoration. 3 months later. At this moment, she was ready to start the orthodontic treatment that she needed. But her parents decided to wait a year. So after 13 months, they came back. And I took a lot of photos and of course an X-ray. So this is before and after a year. And the tooth sensitivity had disappeared completely. 14 months post-op, the lower and upper brackets were placed. In this photo, I am opening the mesiodistal space with an open coil spring to correct the crossbite of the canine. And after some months, I did it. Look at these photos. This is very interesting. I took them just after the patient entered to my operating room. No rinsing, no washing was done before taking them. Look at the upper second permanent molar. It looks completely dirty. Look at the crown and look at the gingival tissue. Looks clean and healthy. 24 months post-op, 28 months. And of course, another treatment option, a good one, I think, would be the extraction of that hypomineralized second permanent molar, waiting for the correct eruption of the third molar in 3, maybe 4 years. These patients' parents didn't accept that treatment option. They didn't accept the extraction of that molar. 40 months post-op. 44 months post-op. The lower and upper brackets were removed. Look at the gingival tissue around the crown. This is the day the brackets were removed. And look at the occlusion. And look at the X-ray after 44 months. I really love this clinical case because it shows an interesting way to restore a severely destroyed, a hypomineralized lower second permanent molar, preserving radicular pulpal vitality. This clinical case is published in the Journal of the Mexican Academy of Pediatric Dentistry on 2019, and that is a great honor for me. I would like to take this chance to invite to all of you for joining us to the Molar Incisor Hypomineralization Forum in Facebook. It is a place to learn, it is a place to share knowledge, it is a place to teach. Please join us on Facebook. And the final question is it possible to do minimally invasive dentistry on a hypomineralized and severely destroyed first permanent molar, I am strongly convinced that restoring a severely destroyed hypomineralized molar, preserving pulpal vitality, using bioactive materials, and restoring with a crown that will last a lot of years, it is minimally invasive dentistry too. This is 18 months post-op. If you need further information about this topic, feel free of sending me an email. I would like to say thank you to all of you for attending to my lecture. Thank you for New Smile for sponsoring this Congress and this lecture. And in Mexico, we say, muchas gracias. Thank you.
Hola, muchas gracias. Thank you, Dr. Jorge Casian. Thank you for this brilliant lecture, very well documented and beautiful clinical cases. So I am pretty sure that people could understand exactly the topic of your lecture in how to use these crowns and when to use them. Thank you so much. But of course, we have a couple of questions here. I'm going to select 2 or 3 because of the time we have.
Okay.
But in general, the questions are going all in the same direction. So I would start with one of them, a couple of questions asking you the effect that the zirconia crowns have on the opposite tooth in the mouth. How much wear you expect from the opposite tooth or teeth, opposite to the zirconia crown in terms of wear?
Well, there are some researches that have proven that a highly polished restoration causes no wear, no excessive wear to the opposite teeth. And the wear of the opposite teeth is more related to the polishing, the lack of polishing. So a highly polished restoration, like pre-made zirconia crowns, don't used to have wear to the opposite teeth. That have been proven in a lot of research. So we know that currently.
Okay. Another question is, in which cases we should prefer to use zirconia crowns instead of stainless steel crown in terms of cost benefit and cost effect?
I think that the indications for placing a crown is almost the same. When you need a crown, but you can choose if you want a long-lasting restoration and if you need an aesthetic restoration. If you want to offer or if the patient is asking you for an aesthetic restoration, and if the patient is asking you a long-lasting restorations, I think that zirconia crowns are a very good option. But the indications for placing a zirconia crown or a steel crown is basically the same.
Okay. We have another question here asking you if you have any experience in endodontic retreatment after you place a zirconia crown.
That is a very good question. And I would like to say that, as I showed you, the thickness at the center of the occlusal surface of a zirconia crown is about 0.7 millimeter. So doing a pulpal access through the crown without removing a zirconia crown is too easy. But that pulpal access should be done with some specific bores, with a round diamond bore with a lot of water. It is too easy to do a pulpal access, and then after the pulpal treatment, after the endodontic treatment, you can seal that hole with resin-modified glass ionomer cement or with some resin cement. And of course, I have a couple of clinical situations where I had to enter for doing a pulpectomy, for example.
Okay. Regarding the period that we are passing through, which is this pandemic era, can we take a special precaution in providing zirconia crowns for our patients?
Well, I think that currently we are not doing big preparations. We are trying to do minimally invasive dentistry. We are in COVID time, so all of us are trying to stop doing preparations. We are trying to place whole technique crowns, to do composite restorations, to do a lot of temporary restorations. So I think that we are not in a good times for working with extensive preparations. We are trying to stop that for these months, and we are doing a lot of minimally invasive dentistry on these times.
Yeah, absolutely. I think we have a chance for one question before we make the final remarks. There's a couple of people asking you your thoughts about CAD/CAM zirconia pedo crowns.
Well, it is not a bad option, but I have to say that a pre-made zirconia crown has a highly polished external surface because it was made with a kind of mold and it was polished in the fabric. So the external surface of a pre-made zirconia crown, like a NewSmile crown, has a highly polished external surface. A handmade crown could have some inconsistencies in the polishing because it is polished by hand. So the wear that could cause to the opposite teeth is completely different. That is why when we are placing a pre-made crown, we recommend not touching the crown with a bore. Because if you touch the crown, if you do some reduction, for example, if the crown is slightly high and you take a bore and you reduce the crown, you will remove the highly polished surface provided by the manufacturer. And the crown will not be the same anymore. So my recommendation is avoiding touching the crown with a bore. And with a handmade crown by a CAD/CAM, you will have some inconsistencies in the polishing. That is what I think.
All right. Well, thank you so much, Professor Jorge Casian. There are so many other questions here. People are very interested in knowing more details about how to use and when to use the zircon crowns, but I'm sure—
No problem. Feel free of sending me an email. That is my email, and will be my pleasure to answering them or sending you some papers, whatever you want.
All right. And I'm sure people are going to be happy to know that you are going to be with us in our next IAPG Congress in June in Maastricht. And
that would be a great honor for me.
Thank you. Even though we don't know already how it's going to happen, the Congress, but people are going to have many other chances to attend your lectures in the near future for sure. So if you want to say final words, I want to make some comments after that.
Well, it was my pleasure to be here. It was my honor to be the last lecturer of this excellent Congress. And congratulations, Marcelo, and all the board of the IAPD. And thank you for inviting me and for this excellent opportunity to share some of my clinical experience. Thank you very much.
Thank you so much. It was very, very good to have you here. A great honor for us as well. You have been with us in the Mexico Congress as well, so it's a great pleasure to go back in our meetings. And I just before we finish this IAPD 20 virtual meeting, I just want to say a few words. And I want to start saying something to the participants. I want to thank each one of the 2,200 participants that we had with us. These participants came from different 90 countries from all over the world, which is great. We can have a feeling that IAPG is really a global and international association. And thank you for the participants to submit more than 800 abstracts. So they were amazing, and a feedback that we had, they were very good. People saying that the abstracts were received some comments from other people. There were very nice inputs. There were exchanging knowledges on that special place where people could talk about the abstract and the poster. So thank you for all of you participants that did this event even greater. I also would like to thank the international speakers. Of course, we had 23 international speakers from different parts of the world as well, from Latin America, Asia, Africa, Europe, and United States, North America, Australia, New Zealand. So we are very happy to have all this family of speakers with us. I also would like to thank the 5 sponsors that sponsored our meeting: DMG, New Smile, Shafu, Cheng Crowns, and Spreak, and also our platinum partner, Colgate. We hope we have a chance to work with you again. It was really, really fantastic. Thank you for the whole support you gave to us to prepare this meeting for all these participants all over the world. And finally, but not least, I would like to thank each one of the board members of IAPG, Ana Maria Viro, our past president, Dr. Ari Kupiecka, our secretary general, and Dr. Jim Crown, our honorary editor, and all 4 representatives of member societies. We have Norman Chinanoff, Young Kim, Figan Samer, and Mariette Wakely. So thank you so much. The board of directors, all the members have worked very hard to put all this meeting together. And also we have to give and ask special thanks for Lorraine and Daphna, who worked very hard. They work for Paragon, who is our associate manager association, and they worked very hard to put all this meeting together. Saying this, now, Jorge, it's time for us to say thank you once again. Thank you for coming. Muchas gracias. And thank you for everybody all over the world.
Hasta luego.
Thank you. We see you. Bye. Thank you.
Bye.